We've got about 25 minutes, maybe a little bit less for questions, and I can ask some, but I'd rather not. So if there are people in the audience, I've already seen three. I'll just try and work right to left. There's roving mics. Do you want to come down to 1, 2, 3, aisle 4? Just tell us who you are, like we don't already know, and your affiliation.
Hi, Cheryl Skolnick, and I'm with Optum, Division of United Health Group. So thank you for all of that, and it's wonderful to see old friends and our new folks. You did a fabulous job. It is a great conference. So let's see, where do I start? First of all, one of the things that I'm curious about is that, correct me if I'm wrong, but not all drugs are eligible for rebates, right? In the PBMs. Not all drugs that are sold through PBM contracts are eligible for rebates. It's about 7%
By
of
eligible.
7% of the
Eligible, they just
pharmaceuticals.
They just don't.
They just don't. They're all eligible. There's just classes where they don't.
The market incentive to give them if you're the
okay,
only
fine.
drug.
Which
So
is
then
why the
practically,
administration
let's
tried to
talk
fix the
about
practice
7%
classes.
of the drugs on our formulary get rebates.
70%?
7.
Stipulated.
Okay. So that leaves 93% for which the rebate policy, whatever it is,
That's not true. Did you say 70 or 7?
7.
No, that's not. I don't believe that, unless you're counting generics at the NDC level.
So for all the drugs on the Optum Rx formulary, 7% have rebates.
Yeah, I don't think
That's,
that's.
but we stated publicly, it's out there for the public record. Okay? My point is, it is not the majority of drugs in the commercial insurance formularies today that are subject to the kinds of rebates that make a difference, number one. Number two, if the employer chooses, the health plans that use that PBM, the pharmacy care services, can now pass those rebates along at retail. So United Health Group has a policy of rebates at retail for the very reason that you suggest, which is those folks need help with affordability. They should see what the rebates are. My question is, beyond that, beyond the question of rebates, there is a big chunk of the rest of the drug spend out there, not subject to rebates, that needs to still be addressed in terms of affordability. Some of it gets to what you're saying, some of it gets to this whole notion beyond, of how do we negotiate, et cetera. Never mind for Medicare, which is a whole nother story, but just even in the commercial area where there is negotiating leverage. I guess my question to you is, given that the industry says, we publish it, we say it's out there as a public statement, that only 7% are subject to these rebates, and we're looking at net price, and we pass along rebates at retail, what are we doing to encourage? Yeah, this is real world. Sorry, this is actually what happens.
Sir Andrew and Mr. Wickman were incredible partners during the drug pricing debate, and I appreciate the fact that they passed their rebates on to consumers. And they're absolutely right that your customers choose to pay you the way they choose to pay you.
Right.
And if they want to hold on to that money, that's up to them. It creates an affordability problem for patients, but that's the patient's issue. I think what you're making a great point on, and I think your question is, what do we do about the drugs that lack competition
What do you
and
do
don't
about
give
the
you a
drugs
discount?
for which you cannot negotiate a rebate?
Right.
And many of those are these very, very high-priced specialty drugs, which are growing and driving part of the unaffordability problem, as well as the demand.
So the challenge with your question, and the issue, one of the issues that I have with HR 3 is the definition of the term single source. So the House defined the bill single source as a drug that lacks generic or biosimilar competition. Who knows when we'll ever see biosimilar competition for some of the specialty drugs that are out there, but they're competitive. So you are getting a very large rebate on Humira, but the consumer isn't getting the benefit of that discount. You would like to negotiate a larger discount on Humira for psoriasis as opposed to what you're paying on rheumatoid arthritis, but Medicare's rules don't let you. If your boss was sitting here, he would tell you that there are probably 10 to 15 drugs that, boy, I wish I had a hammer. because they're protected classes. We can't touch them. Patients are going to scream. But there's a very big difference between a high-cost specialty drug for rheumatoid arthritis that's giving you a very large discount and a high-cost drug for cancer that you won't dare take off your formulary because patients will scream or because some federal rules say that you have to cover it. And those are the companies and those are the drugs that unfortunately have us over the barrel. The administration did try to take that on, but ultimately people with HIV, cancer, et cetera, said, don't you dare touch that. I do think that the House has a very innovative approach. The CBO said last time the reason the government won't save any money is because they're not going to have the guts to kick drugs off plans. The president wants to negotiate. The president doesn't want to negotiate by saying if you're a stable patient on Remicade, you need to switch to another drug. Right. Because as a doctor or pharmacist, like most healthcare professionals would say, I don't think that we should be switching stable patients. And if the government says we're only going to have one drug to treat this condition, they're not going to like it, patients aren't going to like it, and it's never going to have the political palatability to go anywhere.
Let me just chime in because the chart I showed of the percent discounts you'd need to reach sort of fair prices, in many of those cases, we did that analysis based on an estimate of net. And so that did take into account rebates. But you're correct. In classes like oncology, in the gene therapies, when there's no other alternative drugs for amyloidosis, there's little rebate. What we've been talking about with some employer plans and other sponsors is that there's a pay up to approach, which offers broad access. And it says, this is the price I will pay because this is the fair price that matches the clinical benefit patients receive. And if you're not willing to either meet me there through a discount instead of a rebate, something else, call it something else. I know it's sort of playing a game with the system that we already have, but then patients get access. There's no patient screaming because they have to switch off Remicade because it's no longer, your preferred agent. And you have the broad access. What you do with the difference if the manufacturer won't lower the price is an open question that we're open to lots of creative solutions and ideas on.
I don't know that charging a 95% excise tax is necessarily the way that companies will say, okay, you got me. But I agree that a manufacturer would want to avoid that, particularly if the discounts that they were giving were actually reaching your customers.
Great. I want to move to another question. Romila?
Morning. Thank you for a great panel. My name is Ramala Batra. I'm the Chief Medical Officer at Scan Health Plan. It's a Medicare Advantage plan. So for us, the most utilized benefit actually is medications. 93% of our population utilizes medication, and 91% of them are on generics. So $0 or close to $0 copays because we believe in access and affordability. My question is, as we are talking about, we talk a lot about specialty medication prices going up, but if you look at our current data, it's the generics that are going up in double digit as well. So what is being done for that? Because a huge chunk of population is utilizing it, and we want to make it affordable. That's one set. Second thing, as we are moving towards value-based care, our delivery systems are getting paid. It's paid on value-based care. CMS pays us on value-based care, 5-star and all those kind of things. Are there models in Medicare specifically where we could do contracting in those scenarios where CAR-T kind of therapies, where we are paying so much, but there's nothing else we can do? And you also have to keep in mind our population average age is 75, 76. So even if you keep them for 4 years, 5 years in terms of retention, you're not going to see something right away as well. So
I think there are a handful of generic drugs that have taken double-digit price increases, and unfortunately, that's a problem of competition. I think that the fact that generic drug pricing is going up at all is something to be concerned about because it takes away the fact that hundreds of millions of people have saved trillions of dollars since we passed Hatch-Waxman, and generics are really the lifeblood of a competitive pharmaceutical industry. I don't have much sympathy for drug makers, either brand or generic. Once upon a time, they owned the PBM industry, and there were clever ways that they could reward wholesalers for behaving the way that they wanted to. Over time, those wholesalers and PBMs and large vertically integrated pharmacies have consolidated. In much the same way that there are 4 PBMs that control 84% of the market, we now have 3 buying groups, sort of a combination of a pharmacy, a PBM, and a wholesaler, that are buying the majority of the generic drugs. The problem with that situation is if there's only 3 places to sell drugs in the United States, and we get the largest discounts when there are 4 or more generic competitors, then we only see 3 generic products. And when 4 becomes 3 and 3 becomes 2, then 1 buys 2, and then they raise the price. And that's what has happened with some of the handfuls of price increases we've seen. The thing that scares me the most is that next year, for the first time in the history of the Part D program, more than half of the drugs on the non-preferred tier will be generic drugs, because Part D plans have figured out that they would rather get a brand drug and the rebate instead of the generic drug that has a lower net cost.
So I just want to say, both the Title II of H.R. 3 and the Senate Finance Bill deal with an inflation rebate, and that inflation rebate both applies to brands and generics. And I think it works. Now, the other thing I failed to mention is that Grassley reported that bill out, and he only got 6 of his 15 Republicans to go along with him. I mean, it takes courage for a chairman to report out a bill where he doesn't even have the majority of his party. And right now, that inflation rebate part is not viewed. You see more and more now of the McSally just endorsed it. I think Joni Ernst just endorsed it because of the public sentiment. So I think more and more Republicans are going to get behind the inflation rebate, but it's still a ways to go.
They're already paying it.
Yeah, and the other thing I failed to mention is the Senate Finance Bill is like 100 billion, 130 billion of savings, so it does something significant. But in the H.R. 3, the negotiation kind of swamps everything, and so the inflation rebate only gets us another 20 billion or so.
I would also, go ahead, Liz. Go. Yes.
I think you've put your finger on the problem, is that there's many aspects to the problem. There's the generic price increases, there's the brand price increases, there's the launch price, there's the comparison to international. I mean, it's a multifaceted problem, and I think, each has a different sort of public policy solution. But you've put your finger on something that I think we haven't talked about at all. On the outcomes-based and value-based contracts, I think it's a really important point, because it's something where the industry really would support going further there. And I think my understanding is the plan world wants to go there too. The payers want to go there too. There's so many barriers to trying to get those arrangements done. And having sat through enough discussions when I was with J&J, I mean, you've got to have, first of all, there's barriers to sharing information back and forth between the plans and the manufacturers. There's the health IT might not capture the information that you need to demonstrate the outcome that you're trying to contract against. Or you might not be able to tell whether you achieved your result. There has to be an agreement that you've actually, and having sat and listened to enough of these discussions with lawyers, they're really hard to do. And so as much as everyone says, let's go in this direction, I just think they're so hard, and it's sort of a one-off drug with one payer. So for every drug and every payer, you've got to go through this, contract negotiation. It just hasn't proved to be a practical solution to the problem, I think. But I think the will is there.
I think the will is there on that piece, but I also think that there's only a certain amount of drugs for which it's going to make sense. And I think we also have to be really clear about that. And I think CAR T is actually an excellent example. And the new gene therapies are a category where we have so much uncertainty about the duration of effect. We really owe it to the patients, to the people who are paying for it, to everybody, to be very careful about how we're building that into either the payment and rebates and all of those things. I will say that my experience with this is pretty interesting. It depends on the culture of the manufacturer and how many lawyers are there, whether or not they're willing to do these, honestly.
Because there's federal laws that say, if I don't charge you,
listen, there are organizations that have been able to do full refunds on certain drugs, and it doesn't reset best price to zero. And there's something in best price that says that you can do if it's mild, but I mean, some companies are more willing than others. And the other quick thing I would just say on your first question is watch very carefully what happens with Civic Rx, a nonprofit generic manufacturer. That might be how we solve that problem.
Who's currently sourcing drugs from other generic companies.
Okay, we had a
For
question here.
now, everyone starts somewhere, John.
We had a question here in the middle, and I can't see into the light if there's anybody on the other side, but
Hi, Michael Tretton from Intermountain Healthcare. Funny you mentioned Civic Rx.
Tell us how it's going.
I don't know exactly all the details behind it. I talked with the chief commercial officer for a while, Heather Wall, about how Civic Rx was going. I know they're making a lot of progress tackling some of their first set of drugs. To kind of address what was talked about earlier, there is some merit to having private industry take on generic drugs and add stabilization to the market, because part of it is there's generic drug shortages, and then there's also single manufacturers that make just that drug. Like, you think, oh, there's all these other people making that generic, but it ends up getting compressed into like 2 people that control the supply chain. Aside from that, I actually have a different question. So maybe you guys are familiar with the Orphan Drug Act of 1983. Is there anything being talked about as far as abuses of that law? A lot of times you see drugs that have been around for many years that are reapplying for orphan drug status and using the designation in the law for ways it was never intended. That's what's supposed to compensate people for rare drug research, is giving that market exclusivity and research and R&D tax breaks. But when people start applying drugs that have already been through that full cycle and abusing that law, I wonder if that's an issue anyone's worried about.
Yeah, I think Sarah hit on that. The joint letter the other day hit on that. A number of manufacturers are either publicly or privately saying that this is part of the "this is why we can't have nice things" equation. If you start taking advantage of laws that are intended to develop drugs for an ultra rare population of people, and robbing them blind, that's not going to bode well for the industry in the court of public opinion. On the Civica thing, though, I do want to say that I think it's a great idea. I'm excited about the Civica BCBSA partnership, and the ability for people to source generics from someone else that's willing to take them on is awesome, so long as they don't run into the same "who's buying this" problem. I think there are still some questions about whether or not they're subject to 340B discounts or other Medicaid drug rebate program issues that every manufacturer sorts through. But I do agree that it was a breath of fresh air in the marketplace.
Larry Willickson from the Society of Hospital Medicine. Having been a practicing physician, when the government decided they wanted to tell me that I could only charge this amount to a Medicare patient, they had no trouble doing it. When they decided to have DRGs for hospitals, they had no trouble doing it. When you're sitting here thinking about it, why is the pharmaceutical industry in some kind of other world? And it just doesn't make any sense, and it's not consistent with precedent.
You're right.
You're right.
Let me just comment on that, because it's what you're saying is definitely true, but I would argue that the secretary right now, when we instituted the DRG system, we had all kinds of information on what hospitals are getting for Medicare reimbursement, the same way on doctors. Right now, the secretary does not have information to determine the SMA drug, whether it should be at 2.1. We don't know how much R&D went into it, et cetera. So right now, the secretary does not have the information base to determine what a reasonable price is, unlike the DRG system and when we did the physician payment system.
Of course, of course, of course. And it didn't really reflect the cost of the services that you were providing, right? I mean, like, that's the argument that everybody says when the government gets involved in rate setting. It is true that prescription drugs are the only provider for which the government doesn't have a fee schedule. It is also true that the Medicare fee-for-service program doesn't say that my mom can't go to your hospital, but has to go to the hospital of the doctor sitting next to you. So that is a fundamental difference of the way that the government would negotiate drugs. And when I look, Ovik Ra's quote, I want to believe that if CBO says only 8 to 10 fewer drugs are going to be developed, that it really is true what Ovik said, which is that they're going to be the least effective drugs. The reality is, I don't think that's true. And I don't think that Steve Ubel's quote that it's going to be nuclear winter is true. But I also think that it's something in between, because the problem is most drugs are developed via venture investment. And if I'm putting venture money into a potential therapeutic target that hasn't even been really tested in humans yet, I don't know whether that's going to be a great drug or not. So the challenge, it's not a straight line, linear, here's a product that I'm not going to commercialize because it's a Me Too drug, or I don't think it's going to be very important. These investments happen very early in the scale. And if I'm running a multi-sector fund, and you're telling me that I can't be sure that I'm going to get at least a 7% rate of return on a venture investment, or if I'm a large manufacturer that's looking to buy a small biotech company, I'm not going to get at least 700 million in peak annual sales, I'm not going to buy it. I'm going to put that money in self-driving cars or dating apps where I'm certain that I'm going to get a 15% return. So understanding how the investment community works is not something that I think CBO is particularly well in tune with.
And on that note, complete agreement, although I have to say, I think the answer is probably closer to Ovik than it is to nuclear winter. Anyways, join me in thanking our panel, and we'll break for lunch.